All right, so we'll go ahead and get started today. So I have the pleasure of introducing Zach Bailowitz. Give a little bit of brief background on him. So he did his medical school training at the University of Arizona. This then was followed by his PM&R residency at the Carolinas Medical Center. And then finally, he did a sports medicine fellowship at the New York Presbyterian program. He currently is a senior partner in the orthopedics department at Kaiser in Northern California in Oakland. He's additional clinical faculty at the Kaiser School of Medicine, as well as in clinical faculty at UCSF, the Department of Orthopedics. And then lastly, he is the head team physician at Cal State East Bay. And today he's going to be giving us a lecture on the anterior ankle deep peroneal neuroma. All right, Zach, I'm going to stop sharing here.
Awesome. Thanks, Steve, a bunch for the invite. Let's see. Is that showing up there?
Yep, that is perfect.
Okay, awesome.
All right, thanks, Zach.
Okay. Yeah, so I'm looking forward to presenting this case. I've started doing a lot of nerve work in my practice over the last few years. So kind of look forward to talking about these nerve cases as they can be tricky sometimes. I have no disclosures. So let's go ahead and get started. So today we're going to kind of talk about the case presentation. Then we'll review a complete anterior ankle exam. And then we'll sort of discuss kind of what nerve entrapment and neuroma can look like, and then talk about our completed report. Just as a kind of a housekeeping here, the actual case that of the patient I saw was really complex. So I've taken the liberty to make a couple of changes to the case to make it a little bit less complicated. And I've actually, some of the normal ultrasound images were taken from one of my medical students instead of from the patient. So I did that just to make the learning points here a little bit more easy to follow, rather than diving into all the complexities of this particular case. Quick shout out, quick thank yous. Nadios and Lauren were co-residents of mine, and really that's where I got my start ultrasounding. Those of you that are still perhaps medical students or residents, you know, scanning on your colleagues is really the time that you're going to learn a lot. You can watch all these lectures and tons of resources online and all that kind of thing. But if you don't get your hands on the transducer, you're gonna struggle a little bit. So definitely take the time to scan your colleagues. Some of my attendings in my residency and fellowship who were really instrumental in my my continued learning, and also, you know, the sports fellows that I was in the same class with, we still have a group chat where we communicate about difficult cases. And, you know, this is to say that you're always still learning. So certainly I learn more from these guys still all the time. And, you know, staying humble is important, I think, because ultrasound will always give you it always teach you something. So all right, so let's dive into this case. So this is a 56-year-old female with 3 years of anterior ankle pain. She also was describing dorsal foot numbness. She has a history of an ankle arthroscopy about 3 years ago for an OCD lesion. And then a year later, she had a hardware removal surgery as well. She reported that the ankle joint pain that she kind of came in for seemed to improve, but she kind of described this kind of newer achy ankle pain that was anterior, as well as numbness in the dorsal foot. She described the pain as constant aching over the anterior ankle, again with kind of paresthesia, tingling, numbness over the dorsal foot. Pain was 6 out of 10, worse with ankle plantar flexion, which was interesting, and downhill walking. And then she also endorsed some mild axial back pain, but did not describe it as radiating. And again, as I mentioned earlier, patient history has just been altered slightly, both to preserve patient anonymity, but also, again, to make the case a bit simpler. When I teach my fellows and residents, I always try to be very kind of algorithmic in terms of my physical exam. So the IRS pestered students is the mnemonic I typically teach. This is certainly just one order, many orders to do this, but making sure that you're staying, true to the order that you learn. So inspection wise, no gross deformities. There were a couple of well-healed surgical scars. She actually had good ankle range of motion, well preserved and symmetric to the contralateral side. Her strength and sensation, she had 5 out of 5 strength throughout. And when you talk about 5 out of 5 strength in this particular area, you want to make sure that you're checking, of course, the myotomes from a lumbar standpoint. So hip flexion and knee extension, you're still checking. But also you want to make sure that you're checking both hallux extension versus the rest of your toe extension, and also, of course, ankle plantar flexion, dorsiflexion, inversion, and eversion. Her sensation was altered, and she, the interesting thing about the history and the reason I highlighted this case is she kept saying it's my dorsal foot, top of my foot. But when you actually dive into the exam, the sensation was altered a bit at the distal aspect of the dorsal foot, but it was particularly around the web space. And so that's just a sort of, point to say that patients will describe things, but once you dive into it, your exam really will tell you a lot. So don't be hesitant to take out that safety pin or break a little piece of, wood in half and kind of stab there if you're needing to really be specific about where the nerve damage might be. She had some mild tenderness around the anterior ankle. And then if you tap along that anterior ankle, she did have a positive Tinel's, but there was no Tinel's at the lateral lower leg or at the fibular head. And sorry, I didn't include it in here, but her straight leg raise was negative, but full plantar flexion did provoke a little bit of her symptoms. So from a differential standpoint, anterior ankle pain, a lot of times we do think of things like ankle OA or anterior impingement. Extensor tendon tenosynovitis certainly can be something that can cause anterior ankle pain. In this case, I was worried about her deep peroneal nerve, given the distribution of her numbness, as well as maybe some involvement of the superficial peroneal nerve. And then, always thinking about a lumbar radiculopathy as well. So I did have some comparison radiographs. These are not them. Again, the case was quite complex, so I chose to just grab some normal X-rays. When we look at our X-rays, you want to think about a true AP view, which is this one on here on the left, but then also you want to get your mortise view where you can see the ankle joint, making sure that there's no widening on either side. And then you've got your lateral view. This particular lateral view that was quote unquote normal does have a little os trigonum here posteriorly, but we don't see any evidence of any osteophytes or anything kind of anteriorly that would fit with anterior ankle impingement. So there's a couple of different protocols that are described in terms of thinking about how we should image this. This is the AMSSM curriculum update from 2022. And they sort of broke it up into essential, desirable, and optional. From an essential pathology standpoint, they described looking at the anterior joint, looking for an effusion or synovitis. In their particular essential pathology, they describe looking at the ATFL and the AITFL. And of course, that a lot of that has to do with any sort of ankle trauma case that you might see. And then when you jump into desirable, you've got the TIBANT, and then looking for anterior ankle impingement, and then some optional pathology, looking at a few other things that we'll kind of dive into. So, this is a great resource to look through. There's other, descriptions. The AIUM has a description of what they state is necessary for a complete exam. And I tend to follow that a bit more. So this is typically my protocol for every patient. I'll look at the anterior joint. I'll look at the 3 tendons across the ankle, and then the deep peroneal nerve. The ones in italics here are optional depending on what the case is. And so in this particular case, the patient didn't have any evidence of trauma. She had not had any ankle sprain. So I did not look at her ankle ligaments, but I did include her superficial and common peroneal nerves just because of her neuropathic symptoms. So let's go ahead and dive in. Here's our kind of first view. This is the kind of anterior ankle joint. So this first image here on the left, you see your tibia here kind of coming down and ending. Here's the ankle joint itself, and then you've got your talus here. What we notice immediately is the articular cartilage over the top. We don't see any evidence of an effusion. That would be kind of pushing this fat pad up a little bit if you were to see that. And sorry, I tried to use colors around these boxes to correspond with the views here on the left. And then this is sort of your axial or short axis view. This image is directly over the articular cartilage, but you'd be looking at different images throughout that sort of axial or transverse view. And we've got our tibialis anterior tendon here with a little bit of muscle, extensor hallucis tendon with a little bit more muscle, and then your extensor digitorum longus is going to be out here. And you can certainly evaluate the tendons in short axis. I tend to look at them both in short and long, and I find that sometimes the long axis view can be a little bit more valuable. The tibialis anterior is going to be your most medial and prominent of the three tendons. When you're first scanning this, you're always surprised how far distal and medial this tendon goes. So here's the tendon kind of crossing the anterior ankle. This particular, again, this was my medical student here, but this particular tendon did have a tiny little bit of thickening of the tendon right over the ankle joint. So we can see how it's a little bit smaller in width there, gets a little bit thicker here, and then kind of thins out again. So there may be a tiny little bit of tibialis anterior tendinopathy here, although he was asymptomatic. But it's also important to follow it distally. And again, it does extend all the way to the base of the medial cuneiform and even that first metatarsal head. The base of the first metatarsal. And so you want to make sure you follow it all the way distal and medial, as patients can oftentimes be symptomatic there. So here we see a nice view of the tendon coming down. There is a little anisotropy here, so you want to make sure you're correcting for that as you look even further distally. But we did not see any evidence of any tendinopathy at that region. Next, you can look at the extensor hallucis. One of the important things about the extensor hallucis is that the muscle of the extensor hallucis actually extends fairly far distally. So this is the talus, and here we're at the talonavicular joint. And you can see even at the level of the talus, there's still this hypoechoic muscle. And that's important because it would be easy to sort of take a quick glance and say, oh, that looks like some fluid. So there's some extensor hallucis longus tenosynovitis. But in fact, that's just the muscle kind of distal to the level of the talus there. So don't get that confused. And again, just like with our other tendons, if it's indicated, you would follow this all the way out to the attachment, all the way out on the first phalanx there. This patient did not have any tendinopathy, tenosynovitis there. While we're here, we can also look at the talonavicular joint. Again, there was really no symptoms for the patient over that talonavicular joint, but you can see the kind of ligament over the top. We don't see any evidence of effusion here. So that's another place that you can look. Some of the midfoot arthritis patients will have findings there. So that's something you can evaluate. The extensor digitorum longus is a little bit trickier just because at the level of the ankle, it's one tendon, but then as soon as you start going distally, it divides. And so this is a video that I'll play here in a second, but you can see 1, 2, 3, and 4 different tendons over the top of this muscle here. So this is kind of the distalmost aspect of the video. And now I'll go ahead and play it, but just as an FYI, the muscle underneath here is the extensor digitorum brevis. So here we are, there's our tendon. You see it starting to divide out into multiple tendons. And obviously those are going to head towards the 2nd through 5th digits. Again, extensor digitorum brevis underneath looks normal, nice hypoechoic muscle architecture with hyperechoic paramecium, and that'll become important for us later. All right, so we've looked at our ankle joint, we've looked at our 3 tendons across the ankle. The next place we're going to look, I'm going to skip over the deep peroneal nerve for a second, and we'll go up to our other nerves. So remember that the superficial peroneal nerve provides the majority of the sensation to the dorsal foot. And so we definitely want to look at that given the patient's symptoms. So here's the superficial peroneal nerve kind of at the lower leg. This is one of the most common entrapment sites of the superficial peroneal nerve because what happens is the nerve sits underneath this crural fascia here. And then at about 1/3 the way from the malleolus to the knee, it exits the crural fascia and becomes more superficial. And so a common place to find it if you're looking for this is sort of between the anterior compartment and the lateral compartment. It's typically right at the edge of the fibula here. So here's the nerve in short axis. And then if we look in long axis, I tried to highlight the crural fascia, but you can see in long axis proximally, the nerve is deep or underneath that crural fascia, and then it pops out and becomes superficial. And again, that's important because this can be an entrapment site for the superficial peroneal nerve. So it's a place that you want to spend some time and evaluate. The nerve eventually at some point will divide into an intermediate and a medial dorsal cutaneous nerve. And in some cases that happens down towards the malleolus. In some cases that can happen up towards where that typical entrapment site is. And so in this particular patient, we already are seeing the two divisions at this level. Let me go back so you can see that. So again, here's one branch right there, and here's the other. So we're already seeing that division. And we'll watch this cineloop here, starting proximally. There's the nerve. It pops out of the crural fascia, and then it divides into its two branches there. We'll play that one more time. Here's the nerve here, splitting apart there as it exits the crural fascia. And again, as you scan more of these, you'll start to see how variable that division is. Again, sometimes right at the level of the fascia, sometimes a bit more distal. And that's really important because if you are going to see some sort of entrapment, sometimes it's just of one of those branches. So this is a case that I just saw recently where the posterior branch, which is sitting here, versus the anterior branch is quite a bit different. And we can see the long axis view, that anterior branch does have thickening and hypoechogenicity indicative of an entrapment. And I'll play the cine loop here where you can see that. So here's the nerve. It exits the crural fascia, and right where it exits, right there, you can see it becomes quite thickened, hypoechoic. The cross-sectional area increases. And so if this patient, went on to need some sort of release by one of the surgeons that you might work with, you want to make sure that you're saying, okay, this is the anterior branch, the one that corresponds to the medial dorsocutaneous nerve. That way they know which nerve to release. So they can be, it can be very specific in that regard, and you want to make sure you're giving that information. Another case that I had where you can actually see peroneus atrophy. So remember that the superficial peroneal nerve does supply the peroneus longus and brevis. This case was interesting because the peroneus longus was really spared, but the peroneus brevis was clearly atrophic. You see this hyperechoic loss of normal muscle architecture here. And the surgeon was actually kind enough to send me an image of where the entrapment was. And you can see some nerve thickening just proximal to the entrapment site. And you can actually make out distal to the entrapment site, where the nerve starts to look like it's probably dividing into those two branches here with that little probably epimysium band here right in the middle. So remember that when you're scanning these nerves, also looking at what the normal muscle architecture may look like. And that's why I kept pointing out the extensor digitorum brevis earlier on. In our case, superficial peroneal nerve was normal. So let's move on. Now here's the common peroneal nerve up at the kind of posterior lateral knee. Remember that the common peroneal nerve breaks off the sciatic nerve, usually just proximal to the popliteal fossa. And typically it will wrap around the fibular head and then dive down through the kind of fibular tunnel just underneath the peroneus longus. So here we are in the blue corresponds here to above the fibular head. Here's your fibular head here. The nerve can look a little bit flattened here. You'll see that kind of appearance in this picture. But you can compare it to the other side. Some patients will look a little bit more flattened than others. And oftentimes I don't make much of this flattening if the patient is asymptomatic because it can look compressed here. And then here we are a little bit further down. Here's kind of the fibular neck, and there's the peroneus longus muscle, and you can see it's about to dive in. And here's a kind of video of that. So there's the nerve. We see some fascicles there, and then it's diving in underneath the peroneus longus muscle there. So in this particular case, the patient did not have any abnormalities there. And you can also, you know, press with your transducer to see if there's any sonopalpation. This is just a companion case of an intraneural ganglion, which I had not seen before. This case was from a few months ago. Actually, my partner was the first one to see this case. And you can see there's some nerve fascicles on either side of this ganglion that you can imagine could be causing some compressive symptoms. I'm not going to play the video, but you can see the normal nerve here. But there's this just like little blip of a completely almost anechoic, cystic looking structure right in the middle of the nerve. This was a case I actually saw in fellowship of a patient who unfortunately suffered a knee dislocation. So very severe injury, and you would expect some degree of nerve damage with a knee dislocation. So here we are in the popliteal fossa. The tibial nerve looks relatively normal, hyperechoic. You can see fascicular, you can see fascicles here, but the common peroneal nerve or common fibular nerve, as it's labeled here, is almost completely anechoic. You don't see any normal nerve architecture. And you can see kind of the normal common peroneal nerve here, and then it becomes very enlarged. You know, the diameter of the nerve is significantly different from before the area where it's getting damaged here and thickened. So this nerve was kind of swollen, filled up with blood in the area from a traction type injury from a nerve or from a knee dislocation. And this patient actually had essentially no strength with ankle dorsiflexion. So this was a very severe injury. Skip over the video here. So let's jump to our case now. So we're going to go back to the anterior ankle and take a look at the deep peroneal nerve. So this was the view that I kind of started out with. And here we're still at the very distal aspect of the tibia. So a nice place to find the deep peroneal nerve, as it can sometimes be really small, is just adjacent to dorsalis pedis. Here you've got your tibialis anterior tendon and your extensor hallucis tendon here. So in this area, the deep peroneal nerve looks very normal. I'm going to risk playing this video just so we can take a look. We'll start off at this view and then we'll go distally. So here we are. And then all of a sudden you see this large bump off the nerve. I'm not going to play it again so that this doesn't explode on me. But to take some pictures of it, here's the kind of swelling of the nerve that you can see both in short and long axis. And a couple of points to look at. First of all, make sure you're taking measurements of these kinds of things. I think that's important, especially if you're thinking about sending them to a surgeon. But also when you look in the long axis, you want to make sure that you see nerve continuity, both proximally and distal to the nerve. And that's important because you want to be able to say that this is a problem with the nerve itself. This is a mass or neuroma within the nerve rather than just some sort of problem compressing the nerve, because that can help distinguish what type of structure you're looking at. So again, it's measured here. We see normal nerve diameter all the way to here. There's the swelling and then normal nerve going distally here. So for our report, I want to highlight a couple things. Number one, I'm fortunate enough to have a nice hockey stick transducer that's really high frequency. And so I use two different transducers. Oftentimes I'll use my 15.6, which is kind of the linear that is kind of my workhorse. But then when I'm looking at nerves, and specifically if I do see some abnormalities here, I'm switching. So I mentioned that both of those are being used. Again, our anterior ankle joint was normal. Our tendons, you know, there was some mild thickening of the tibialis anterior that I did mention, but I'm not bringing that up because the patient didn't have symptoms with palpation there. And then the way I describe this is at the level of the anterior ankle, there's a 0.3 by 0.5 by 0.7 centimeter focal mass. And then again, that verbiage in continuity with the deep peroneal nerve. It does appear relatively homogeneous. And my apologies, I didn't have a picture of the Doppler, but there was minimal flow on power Doppler. Sonopalpation over this region reproduced the patient's symptoms of tingling. And then there was no atrophy noted of the extensor digitorum brevis. And we'll talk about why that's important in just a second. So my impression is that there's a deep peroneal neuroma at the level of the anterior ankle. So the peroneal nerve, as we all know, branches off the sciatic nerve, typically again, right above the popliteal fossa. It's got innervation from L4 to S2. And the common entrapment sites that we think of, again, most commonly at the fibular head, at the common peroneal nerve, but then also the superficial peroneal nerve can get entrapped at that crural fascia exit, like we talked about. And the deep peroneal nerve can get entrapped at the anterior ankle, not just in the case that we're seeing, but also sometimes in patients without a traumatic history underneath the retinaculum at the anterior ankle. The deep peroneal nerve specifically branches off the common peroneal nerve, typically right around that fibular neck. And it's an interesting nerve because it passes, it typically runs initially in the lateral compartment, but then it passes into the anterior compartment. And that's important to know when you're thinking about chronic exertional compartment syndrome. It does branch out into medial and lateral terminal branches. Variably, this branching happens somewhere around along the dorsal foot. And above the ankle, it innervates the three kind of ankle tendons that we talked about, tiband, extensor digitorum longus, and extensor hallucis longus. Below the ankle, it does extend some branches to a few of the kind of dorsal but intrinsic foot muscles. And again, that's important. So if you recall in our case, we didn't see any extensor digitorum brevis atrophy. And so it's nice to be able to say, well, while there is a clear neuroma here, we're not seeing muscle damage or muscle wasting, at least sonographically. Whereas that peroneus brevis atrophy case that we saw, that one clearly was a little bit more severe of an injury. The sensation that we typically think about is just that kind of first web space. But again, there's a lot of variability with this. And, many of us have seen patients, for example, with carpal tunnel, and, they're supposed to say that it's just those first 3 digits where they get numbness, but they might say it their whole hand. And sometimes that's a patient experience, and sometimes that's maybe a aberrant nerve. But regardless, hearing the patient say, oh, it was the top of my foot, I could have just scanned the superficial peroneal nerve and called it a day and not seen any abnormalities. So making sure that you're being thorough with your evaluation. I just wanted to include a couple of slides here because we see these kinds of things fairly frequently, but what is a neuroma? Why does it happen? Most of the time, these are benign. They're typically well circumscribed and usually painful. They can be divided into neoplastic, traumatic, or syndromic. And the typical pathophysiology, at least with the traumatic ones, is that you get an injury to the perineurium. The axons sort of escape into this extraperoneal space. And then the inflammation that's there, whether that's traumatic or compressive, causes unorganized axonal growth outwards, which ends up forming neuroma. On ultrasound, we typically see an enlarged nerve, again, in continuity with the normal nerve, both proximally and distally. In terms of traumatic neuromas, the ones that we think about most are Morton's neuromas. But you can also see stump neuromas in your amputee patients. And then again, post-surgical neuromas or post-traumatic neuromas can happen as well. This is in contrast to nerve sheath tumors, which typically don't come from trauma. And they can be either schwannomas or neurofibromas if they're benign, or this very rare category of malignant peripheral nerve sheath tumors that typically come along with neurofibromatosis type 1. Those of you that do a lot of scanning, you'll without a doubt start seeing lumps and bumps. And this paper from Jacobson from last year is really a valuable paper that talks about different types of lumps and bumps and what you might see. There is a little section on benign nerve sheath tumors. And I think one of the things to think about when you're seeing these is, gosh, is this something that's actually malignant? Do I need to really be worried about this? Some of the atypical findings for benign lesions, central necrosis, rapid growth, poorly defined margins. These are all going to be things that kind of push you in the direction of thinking about maybe needing to be a little bit more aggressive in your workup of that particular lump or bump. This paper actually tried to define statistically different criteria that fit with benign or malignant nerve sheath tumors. And they also found that benign were more likely to be well-defined, encapsulated with mixed echogenicity. But they admit that the gold standard is still pathology, so you need to biopsy these things if there's any sort of concern. Now, not every nerve entrapment forms a neuroma. You can just see fascicular changes. You can see enlarged cross-sectional areas without a true neuroma formation, or you can see hypoechoic nerve tissue just due to the loss of the perineurium and those fascicular changes. And I just wanted to highlight this paper from Dan Cushman and his colleagues, because up until this paper was published earlier this year, there really wasn't any great resource for looking at nerve cross-sectional areas outside of the median and ulnar nerve, which are very common. And so this was a great resource for me to have. And I've started looking at this a little bit more when I'm scanning. Unfortunately, there wasn't enough data for them to include the deep peroneal nerve at the ankle, but there's a lot of other common entrapment sites of different nerves that can be valuable for you if you're doing a lot of nerve scanning. So that's all I've got. Thanks so much. These are my references, and sorry for the technical difficulties, but appreciate your time this morning.
All right. Well, Zach, that was awesome as always. I mean, beautiful images, beautiful cases. So really appreciate it. And just kind of a couple of points, to kind of make and comments off the presentation. Really appreciate you kind of going over the peroneal anatomy. You made that look really easy, but it can be really, really complicated. And so kind of all the little nuance points that you made about the common peroneal, superficial, deep. I mean, those are important things, especially if these are going to be, surgical cases. That are going to need, operative decompression or anything like that. So, and kind of one point that you made off all of these is that even though this was an anterior ankle case, you had kind of pointed out, which I think is key, especially as you're starting to do these scans, is don't immediately just go to that joint to try to find the nerve. Sometimes I think that can be very, difficult. You can get lost pretty quickly. So scanning proximally, like you had shown with these nerves, is key, especially just because they can have such, variable anatomy and branches and things like that. So when in doubt, just go more proximal at those locations and kind of scan them distally, even if it's all the way up at the knee, I think is going to be key for these kind of peroneal nerves. One thing I would mention kind of on the protocol, sometimes one other structure that I'll include is just the subtalar joint as well too, especially laterally. Occasionally I've just seen some ganglion cysts that can become pretty, large. Obviously, clinically that's going to be pretty obvious, and you'd probably be more concerned at that point. But that is just one other, structure that I'll kind of add in occasionally on these scans, whether it's the medial or lateral. But in some scenarios, those can kind of compress on the distal branches of the superficial and deep peroneal nerves. As you had mentioned, you kind of really hit the highlights, I think, for neuromas. I think, as you're getting started out with these, the biggest thing to be looking for is you're going to be having hypoechoic thickening. But the big key is, as you had mentioned, you're going to have continuity, with the nerve, both proximally and distally. And obviously that's going to be what's going to differentiate, potentially other, soft tissue masses, like ganglion cyst. And then in addition, as you had mentioned in your report, is that they had direct sonopalpation tenderness, over that area. So I think those are always the real kind of keys that if you're trying to describe this in the report, those are all important, factors to know. And then lastly, just, you had mentioned kind of the deep peroneal, and obviously this was a case of neuroma. Other cases that I've seen for deep peroneal or the superficial peroneal neuropathy, just in the ankle and foot, is going to be ganglion cysts, as well too. And so that's important that if you're getting x-rays and things like that, to go ahead and look for any underlying, arthritis pathology, any type of hardware that might be causing, compression and doing these scans. But ultrasound is then a real effective modality to kind of differentiate between those neuromas and ganglion cysts, just because those can arise at the tibio-talar, subtalar joint, talar navicular joint, and those can always cause, compression in the peroneal nerve distally as well too. But yeah, thanks so much, Zach. I mean, you made so many, great points, throughout this presentation, that it's going to be really helpful. But I'll go ahead and open it up to anyone else, or Zach, I don't know if you have any comments following that.
No, yeah, I mean, I think your point about the different, areas of some of the joint kind of ganglion cysts and things like that is a really good one. And as I said, this patient's case was actually a bit more complex than this. given her surgical history. And so I did spend quite a bit of time kind of looking through the course of these nerves, because there can be other areas of scar tissue and entrapment and that kind of thing. Unfortunately, I didn't see anything, and so I kind of left it alone so that wasn't part of this. But yeah, these kind of midfoot, arthritis patients can have all sorts of areas where, these little branches of the nerves get irritated. And frankly, sometimes the branches are so small that even with these high frequency transducers, you're not able to see them. But sometimes if the case fits in terms of their symptoms, if they're having, neuropathic type presentation, and you see some sort of ganglion cyst or some sort of, pretty impressive synovitis or something at one of these joints, sometimes just treating those joints, you're going to get an improvement in some of their symptoms, even if you can't identify the exact little focal branch that's getting entrapped. Because admittedly, there's so much variability. And the other point to make is just that part of the reason that those three entrapment sites, the anterior ankle, the superficial peroneal nerve at the crural fascia, and then the common peroneal nerve, are important is not just because those are common entrapment sites, but those also happen to be areas where we can kind of reliably get good visuals of the nerves. And so, don't hesitate to kind of start at those spots, because you'll be able to visualize the nerve so well there. And then you can track it proximally distal wherever you need to go, and hopefully be able to visualize it along the length of the nerve, which, that's where just like scanning these takes time. But, when you're first starting out, you may be worried, oh, where do I put the transducer? How do I find those nerves? They're so small, I can barely tell. It just looks like a little tiny bump. And so, finding those reliable sites where you found it and you can visualize it is a great way to kind of track it proximally and distally. So I think that's all I've got.
And then I think just quickly, Zach, and then in this case, did you end up doing like an injection for the neuroma? Because obviously, I mean, it's not going to be, from a scanning protocol standpoint, but obviously in these neuromas, when we're looking, what to do next, obviously you can do an ultrasound guided injection to kind of be then diagnostic and confirmatory that yes, this is, what's causing their pain.
Yeah, I actually did. We talked a lot about it, about whether or not, because I always think about these injections being more helpful for sort of compression neuropathies rather than like true traumatic neuromas. But ultimately, she was in so much discomfort that we proceeded with an injection. And she's emailing me, now it's been about 3 weeks since I've seen her, and she's emailing me telling me that her pain has decreased. She says it's certainly not gone. So, hard to know how long that decrease will last. But she is reporting some improvement in her symptoms. And so hopefully that will continue to improve. And if not, then that would be someone I would probably have my peripheral nerve surgeon see.
And then with those, the kind of injections, are you always going then just like slightly proximal to that neuroma where you're getting that and then just kind of spreading then down distally?
So I'll typically approach it, sort of in a short axis or cross section to the nerve. And if there's like an entrapment site, then I'll typically go just proximal to it as you outlined. In this case, because there's not really an entrapment, I just tried to put I used a little bit of corticosteroid and then mostly D5. And I just tried to put that exactly around the nerve as best I could, right around that neuroma.
All right. Well, otherwise, then, yeah, we'll go ahead and wrap it up, and then we'll have another presentation in 2 weeks that we'll be sending out another announcement for another case in this series. But thanks again, Zach, so much for doing this.
Yeah, man, absolutely appreciate the invite, and looking forward to the continuation of this case series. It's been great.